Great. I can see a few people joining, so we're just going to have a minute or so whilst we get to 7 o'clock UK time. So we'll just give it a few seconds if that's okay. Okay, I think it's 7 o'clock UK time, my time here. So I think we'll probably start with this evening's or this morning's or this afternoon's webinar, wherever you may be. So first of all, thank you for joining us. I'm really pleased to announce the third webinar that we're doing with our specialist team here at VET.CT through our consultancy team. Today we've got a really interesting topic, managing chemotherapy and adverse effects with Charlotte Johnson, who's one of our oncologists here at VET.CT Teleconsulting and Consultancy. And so I'll introduce Charlotte in a second. Charlotte, she's got control of the slide deck, so do you mind just moving the slide deck forwards? So my name is Richard Artingsell. I'm Director of Teleconsulting. I'm not going to take up too much time, but what I do want to talk about is our consultancy services and how we're here to help you. So as you probably know, because you've registered for the webinar, VET.CT is a global team of over 200 specialists, and what we excel in is providing exceptional radiology, consulting and educational services. So the webinar series that we're doing is every 2 weeks, every Tuesday evening. They're all recorded, so anybody who has registered and is watching this recording will get a recording through their email, and you can watch them back as well, and then they'll be on our website as well. But this is going to be delivered by our consultancy team, our specialist team. In particular, the specialist team is made up of over 55 different specialists and 11 different disciplines. And what it enables you to do, it's a very different way of working in practice. It's like having a specialist extension to your team or to you as an individual. When we excel in written specialist case advice within 12 to 24 hours, certain disciplines, internal medicine, oncology, neurology, exotics, and others, we can have instant callbacks, asynchronous text chats throughout the day, and also booked appointments as well. So certainly our oncology team are available for all of that as well. So essentially what it enables you to do, it enables you to get support from our friendly specialists, and all of them are friendly, I guarantee it. And it helps you treat things in-house or just make more logical clinical decisions if you need to make referral. We find, and the feedback we get is it massively reduces stress. It gives you clear and detailed next steps on case management. Has a massive impact on clients. Clients are delighted to stay with the primary vet in charge, and just knowing and trusting that they've got support of specialists. You get fast turnaround written advice. And within all of our services, it's the consultancy services, it's unlimited follow-up. So you can have that conversation as that case goes on. There's no hidden charges on that. So you can take a subscription, or you can take what we call a pay as you go. You just don't need, we don't mind. Get individual reports as you need them. So if you do have a phone and you want to go back and scan the QR code, we've got all the information there on that QR code. And I would just say, use us and give us a try. It'd be fantastic to have you as part of this new way of working. Next slide, please, Charlotte. So just a bit of housekeeping today. Everyone's going to be on mute, and this will be recorded, so everyone will get a copy of the recording afterwards. We have a Q&A box in the chat room. If you've got any questions, pop them in there, and I'll be going through them at the end as well. And we can hopefully answer any of your questions as we go from there. So final slide for me, please, Charlotte. So yeah, great pleasure in introducing Charlotte today. So managing chemotherapy and adverse effects. As I said, Charlotte's one of our oncologists, one of 5 oncologists here in VET.CT consultancy, working throughout the day, 24 hours a day. We've got access on written advice and stuff like that. So please, if you've got any oncology advice that you need, just reach out to us and we can help. So over to you, Charlotte.
Great, thank you very much, Richard, and welcome everybody this evening. I think this is the first oncology webinar that we've been doing, and I suppose wanted to start with a fairly broad topic for us to talk about. In the teleconsulting side, we do certainly get quite a few questions about chemotherapy, what chemotherapy to give, when to give it, should we administer it today based on our blood work. So I was hoping that this webinar would give you a bit of an oversight on things, maybe highlight a few areas that are important to consider and think about sort of during a treatment protocol. Also now with various different companies being available, particularly companies where you can get your chemotherapy delivered on site to you in the clinic in a safe, closed system fashion. It means that it is safer for you to administer chemo in clinic, and it may mean that there are cases that you can keep in clinic and not have to consider referral. And certainly we're here to kind of help and guide you through all of those processes, if that's something that's possible for you and suitable for client and patient. So today, I guess it is sort of fairly back to basics with chemo, but what I wanted to touch on and go through is from the beginning, what are our chemotherapy drugs doing, and maybe what body tissues are going to be inadvertently targeted by chemotherapy. We know that there are various different factors that can influence whether a patient gets some form of adverse event secondary to chemotherapy, and trying to understand how that influence may happen, what we maybe do to alter that or influence things for the better for the patient. And when we do have adverse events, what can we do about them? Is there a way that we can prevent them? Is there ways that we monitor them? How do we treat them to ultimately give the best care to our patients? So going back to basic chemotherapy principles, this gives us the underlying reason why we can get side effects. And chemotherapy drugs, if we think about what we would call maximally tolerated chemotherapy, where we're giving the dose that is sort of the tolerable level for the individual patient, those chemotherapy drugs are going to target cells that divide really quickly. So that's our kind of classic chemo drugs. It's not quite the same as our tyrosine kinase inhibitors, so drugs such as Palladia or Massivet that you may use in clinic. We're particularly talking more about your conventional, your doxorubicin, vincristine, vinblastine, etc. There are normal cells in the body that undergo this same rate of division. And that's why we're going to get side effects, because those cells are inadvertently going to be targeted by the drugs. And the key areas that we tend to think about that we monitor most closely will be the bone marrow, the gastrointestinal tract, and to a lesser extent, your hair follicle cells. And so kind of going back to these very basic principles gives us an understanding about why things happen. Knowing why things happen helps us then understand how we can alter it or how we can treat it as well, and what to expect. When we're thinking about chemotherapy, obviously one of the first things that we need to consider is when are we going to give it? Not all type of oncology case or type of cancer is going to require or be sensitive to chemotherapy. So it is important to, from the beginning, understand when we might look at using it. So fairly straightforward. If we have a disseminated or a systemic form of neoplastic conditions, such as lymphoma, and we know that we're going to require some form of systemic treatment. And in dogs, lymphoma doesn't typically present just in one lymph node. And despite owners saying to us, can we not just remove all the lymph nodes, we know that that's not going to benefit their disease. So we need to be able to give some form of treatment that's going to go body-wide. There are certain tumours that we treat that may be really sensitive to chemotherapy, and others that maybe aren't. So, knowing what we were going to expect with some form of treatment is going to be helpful. So, certainly tumours that are very sensitive to chemotherapy are going to be key ones that we're thinking about in terms of this form of treatment. And chemotherapy can be divided to some degree as to whether we're giving it as sole treatment, or adjuvant chemotherapy, or potentially neoadjuvant chemotherapy. So adjuvant chemo is probably the best example, maybe something like osteosarcoma or hemangiosarcoma, where the patient has undergone some form of local disease therapy. So spleen has been removed, leg has been amputated, and we know that in those cases, the disease generally has a very high rate of metastatic consequences. And that metastatic disease is typically there on a microscopic level at the time of the initial therapy. And so we're using chemo to try and target that following the local treatment for the disease. Neoadjuvant chemotherapy is maybe not something you're doing quite as frequently in practice, but is something that we may do to try and reduce the burden of disease, or maybe reduce the size of a tumor to make it more amenable to other treatments. So maybe your classic example for this would be a mast cell tumor, where we want to try and reduce the size of it to then maybe it's a surgical candidate where it wasn't previously. That was maybe not an option. We do have some situations where you might classically think chemotherapy is not indicated when yes, we've got maybe more effective options, or we have a tumor that's maybe not going to be sensitive to chemo. I would think about that, you know, with a bit of a pinch of salt, in that there are certainly some instances where we maybe use chemotherapy, even though we know it's not going to be effective to put the patient into remission, or we know that that neoplastic condition on the whole is not super sensitive to chemotherapy. However, based on multiple other factors that can be the patient, the disease, the owner's preferences, you know, other comorbidities with the patient, we may elect some form of chemotherapy as that's deemed to be the best treatment option for the patient, given the full picture. So I think it's important that we're looking at big picture, and we're not always just looking at tumor diagnosis and how best to treat that. Most of the time in veterinary oncology, our most important factor is the patient's quality of life. When we're talking about chemotherapy, often the higher dose of chemo that you give, it may be more effective for the tumor and reducing that burden of disease or sending them into remission. However, we have to balance that with the adverse events that could develop secondary to the drug, just based on, as we were saying earlier, these normal cells in the body being inadvertently targeted. So it is an ongoing balancing act between an effective treatment and the side effects that we might see. And that balancing act for the individual patient may be different based on their tumor, their comorbidities, their goals with treatment as well. So again, it's not a one size fits all. And ultimately, the end goals often in veterinary medicine for our oncology patients is that we want best quality of life possible. And the goal with our treatment is some form of improved prognosis and improved survival time. So moving on, when we talk about adverse events, what are we typically thinking about? What do we see, and how do we monitor and manage these? So thankfully, for most of our patients, the risk of us having a very serious adverse event secondary to chemo is fairly low, if we compare it to some degree to human medicine. And that is often because we've got slightly different goals with our treatment. But the risk of a fatal consequence is very low, which, you know, from the owner's perspective, I think that they're always worried about chemotherapy and kind of what we're going to see. But we can present to them right from the get-go that the chance of us having really serious side effects is often extremely low. The other things that are great about most of our cases in our treatment is that even if they do experience an adverse event, and even if they require hospitalization, these patients normally recover very quickly. And that most of the time we have ability to try and reduce the chance of that adverse event happening again. We can't completely get rid of that chance or guarantee that it's not going to happen again, and that's something that's important for owners to be aware of. But a lot of the time we can look at managing or modifying maybe what we're using for additional supportive medications, such as our antiemetics. Maybe we're looking at changing doses or using different drugs, different protocols. Every dog and every cat is very individual. And so it is a bit of tinkering. So it's definitely not, oncology is not black or white, and it's not a one size fits all, which I think sometimes we can be led into believing that may be the case. But there is a lot of things that we need to be assessing and monitoring and changing to ultimately, hopefully, provide the tailored treatment for that individual patient that gives them the best outcome with minimal side effects. There are certainly lots of contributing factors that we need to think about in our patients that help us understand what increased risk there might be, and having that as factors that we consider when we're trying to determine what protocol we want to give. So understandably, drug is a key thing. So we know certain drugs are going to be more likely to cause certain side effects than others. Maybe they're more likely to have an effect on the bone marrow. Maybe they're more likely to affect the gastrointestinal tract. So already knowing what drug we're going to use, we've got an understanding of what to relay to the owner as things that we need to monitor closely for, or what would be most likely the concern that we might have if we do see an adverse event. Of course, with that dose of drugs, so again, we know that if we're using maybe a much higher dose of a chemotherapy, you're going to more likely see some adverse events. We also know that depending on the size of the patient, we may be more or less likely to see some secondary events. As you're probably aware, when we dose chemotherapy drugs, we typically dose them per their body surface area, which is flawed, as is doing it by kind of their weight in kilograms. There's no sort of great option in terms of dosing, but with their body surface area, what we do generally feel is that the smaller breed or species patients are potentially getting kind of their pretty much on the border of their maximally tolerated dose. Your large breed, your giant breed dogs are maybe getting underdosed. So it does mean that we are considering that when we're formulating a dose, and for some of our drugs, when we're giving them to very small breed dogs or for cats, we may have a slightly different dose that we're using. With patients, of course, a lot of the time in oncology, we may be dealing with the more senior population, and those patients may be more likely to have comorbidities. So whether that's a cat with underlying chronic renal disease or some hepatic dysfunction. We know that some dogs have a more sensitive gastrointestinal tract than others, and that's something for us to consider. And in particular with chemotherapy, we want to be aware of any dogs that we might have concerns about having MDR1 mutations. So remembering these are the dogs, maybe classically breed-wise, we think of Australian Shepherds, Shelties, some Collies, that if they do have that mutation, we know that secondary to certain chemotherapy drugs, they're going to have a much higher chance of adverse events, and we do definitely modify the dose of the drug that we may be giving if they have a mutation. So therefore, if we have certain breeds that come into the clinic, if I'm thinking about giving chemotherapy, then I'm being aware of that we might need to do what is a fairly straightforward, simple blood test just to check whether they have the mutation. With dogs that are presenting, or cats that are presenting with various cancerous processes, they're going to present in varying different degrees of kind of a clinical status. So we might have a patient that's feeling pretty unwell from their disease, or we might have a patient that's presenting that feels completely fine with no comorbidities. If we say, take the example of a dog that maybe has lymphoma, they're feeling unwell because of their disease, then when we start chemotherapy, we may look at using initially a dose of a drug on the lower end of the dosage range to be able to treat their disease and help them feel better without that risk of maybe too much of adverse events. And then once they're feeling better, we might be able to push it a little bit more with dose to try and get the best outcome. The other thing to consider, of course, where is the disease? So if we have a dog that maybe has a gastric tumor and that's presenting with signs of nausea, vomiting, anorexia, maybe if we have a type of gastric tumor that doesn't respond very well to chemotherapy, we have to weigh up the pros and cons of treatment and try to consider, are we actually going to make the patient feel better? So we just have to have all of those considerations when we're thinking about drug and dose and our goals with treatment. When we think about toxicities and adverse events, we can typically divide them into 3 categories. Probably the classic ones that we think about that you're probably aware of or considering when you're in practice as the side effects that occur a few days after treatment, and those are the ones that are affecting the bone marrow and your GI tract. But we do know that there are some side effects that you can see at the time of administration. And probably the one that we worry about is when we're using a vesicant and having episodes of extravasation. But there are some drugs that we might get a hypersensitivity reaction, or that we can induce nausea or vomiting right at the time of administration. And then on the other side of the spectrum, we may be continuing these drugs for a period of time, maybe not indefinitely, but maybe over a period of a number of months. And some of them we maybe have cumulative toxicities to be aware of. So that might be hepatic dysfunction with lomustine, or cases like doxorubicin, we worry about cardiac toxicity. So other spectrums of these adverse events that we need to be aware of and monitoring for and making owners aware of as well. So if we focus on the bone marrow to begin with, if we actually look at, I guess, the cells that we're conscious of and focusing maybe on their lifespan in circulation, it's fairly easy for us to then understand why chemotherapy has the greatest impact on certain cells within the body. Your granulocytes, in particular, neutrophil is the one that we probably have the keenest interest in oncology, and platelets, their lifespan, their turnaround time is fairly short. If you compare that to your red blood cells, they obviously have a much longer lifespan circulation, and that helps us understand why generally we wouldn't expect to see a massive drop in your hematocrit following chemotherapy. Sure, we can get signs of anemia of chronic disease, but if I have a patient that has a significant drop in their hematocrit between chemotherapy treatments, my first thought isn't due to chemo, is there's another underlying cause. Of course, if they have maybe a bleeding tumor, then it certainly can be related to the disease, but it certainly is not something that I'm thinking that's due to chemo. And therefore, while we monitor for anemia and we monitor our blood cells, it's not something that we are expecting to see significant decreases in due to treatment. So as we just said, that probably the 2 cells that we have biggest thoughts and concerns about are our neutrophils and our platelets. Given the turnaround time and the lifespan of our neutrophil, we tend to find that the neutrophil nadir, so the lowest point after treatment, is between 5 to 14 days after they've received their chemotherapy. That varies between drug. It's going to vary between individuals, and the average time is about 7 days. However, we have to appreciate that certainly sometimes things can vary, and when we're looking at monitoring for that, that's important for us to know that it's not, dead set that at 7-day point that's going to be the lowest. Maybe it's day 6, maybe it's day 10. If you have been doing any chemotherapy in practice, you will quite frequently have seen probably some degree of neutropenia. And the prevalence that we see is certainly going to be dependent on drug and dose. How do we monitor? So thinking about when we typically see the low point, it generally means that we're often checking their neutrophil count about 7 days after treatment. Of course, we always do it on day of treatment as well, but trying to capture that roughly nadir point to understand, are we giving a suitable dose? Do we need to reduce it? Have we got a significant neutropenia that's not ideal for the patient? And I think the most important thing probably to consider of every part of chemotherapy and giving that in practice, if you have a neutropenic patient and they are febrile and they're feeling unwell, that is an emergency. You know, we need to be acting on that swiftly. Those patients need to be hospitalized, they need fluids, they need IV antibiotics. So we need to be monitoring for that, and we need to be conscious that that can be a quite significant and concerning adverse event if it happens. Looking at your neutrophil count, generally speaking, and how I look at my neutrophil count when I'm giving chemotherapy, the values that you see on here is specific to me. So you have to kind of formulate what your comfort level is in terms of when you're happy to give chemotherapy based on their blood work. And that's going to vary. So for me as an oncologist, I'm seeing patients that are going through chemotherapy on a daily basis. So I probably feel more comfortable being in a situation that if they are slightly neutropenic, that we're happy to go ahead. But you shouldn't feel obliged to follow this. You know, for some oncologists, they want values to be higher, or they want the neutrophil count to be within the normal range. So my, I guess, advice to you is to come to a level where you feel comfortable about administration of chemotherapy. So from my side of things, if I have a neutrophil count that's above 1.5, patient is feeling fine, then we can go ahead, if they're due treatment that day, that they can go ahead and receive their treatment. If I have a patient that their neutrophil count is less than 1.5, then for me, that's a point where we say, no, we need to wait a little bit longer. We need the body to have some a bit of regeneration for that value to be a bit higher before they can receive treatment. However, if they're feeling fine, you know, off they go home, and we see them back then to get treatment in a few days. In terms of cases where we need to be a little bit more active, so for me, if I have a patient that's still feeling absolutely fine, they're not febrile, but their neutrophil count is less than 0.75, then I'm going to be sending those patients home with a short course, generally 5 days of some broad spectrum antibiotics. However, as we said on the previous slide, certainly if I have a neutropenic patient, if their value is less than 0.75, they're febrile, they're unwell, and they are in the clinic and being treated aggressively. The one exception to all of this is if you have a neutropenia that is caused by the disease. So again, maybe if we have a patient that has lymphoma, maybe the lymphoma is involving their bone marrow, secondarily that is causing a neutropenia. The only way to improve that neutropenia will be to treat the disease. So if they haven't had any treatment, we know the neutropenia can't be secondary to chemotherapy, but we then need to treat the disease. The complicating factor that can occasionally arise in these situations is if you feel that you have a patient that is neutropenic because of their disease, they haven't received chemo, so you go ahead, you give their first chemotherapy treatment, they come back a week later and they're neutropenic. And is that neutropenia secondary to the disease or secondary to the chemotherapy? And those are cases that are a little bit more tricky to interpret. We're not faced with them very frequently, so not something that I would be worrying about or getting to think about too much, but more the concept of if they're neutropenic without any treatment on board, and we think that's due to the disease, then you can certainly go ahead and treat. What do we do if we have a neutropenic patient? How do we try to, I guess, manage, or what do we look at doing kind of following their improvement after treatment? So I guess one of the things to consider is often if you have a neutropenic patient, one of the biggest worries that we have is translocation of bacteria from the intestinal tract. So being aware of that in those patients, and neutropenic patients, particularly patients that may be in the hospital. Generally speaking, because the neutrophils are regenerating very quickly, their count normally rebounds very quickly, and so it will, generally speaking, be back or increased certainly within a couple of days, and therefore hopefully there's not too much of a delay of getting them back on track to treatment. And for me, I guess the other question is, what do we do next time? So do we give the same dose or do we change the dose? What I generally recommend, if their neutrophil count went below 1 following that treatment, or if they did have a septic or febrile episode, then I would look at doing a dose reduction, and typically about 10%, and close monitoring of them following that subsequent treatment. Thrombocytopenia is something that we see certainly less frequently than the neutropenias, and is definitely something that we see more commonly with some drugs than others. So as listed on the slide there, melphalan, lomustine, chlorambucil are key ones that we tend to think about a little bit more, either in the kind of acute setting soon after treatment, or maybe more like with your chlorambucil if they are on it for a long period of time, maybe your cats with small cell lymphoma, something like that. I do have a cutoff point for platelets as well. So if they're less than 75, then I don't treat and wait a little bit longer until hopefully that count has increased again. Similar to the neutropenia, the one exception to that is if we think that thrombocytopenia is due to the disease. In those cases, we may be comfortable treating or thinking about maybe what drug we should use. Moving on to GI tract. So most of our gastrointestinal disturbances that we get are normally pretty mild and generally fairly self-limiting, which is great. The classic ones that we will generally think about are the chronic side effects that are occurring a few days after treatment. However, there are some drugs that might have a direct impact at the time of administration. So that is something that we need to be aware of. The side effects that are occurring a few days after treatment are because of the impact on these gastrointestinal crypt cells, which have a high rate of cellular division, therefore are going to be affected by the treatment, but also means that they regenerate and things improve pretty quickly. So you tend to find with dogs, if they do have any gastrointestinal upset, that it's a fairly rapid recovery, often with fairly minimal interventions. We generally will worry about nausea, vomiting, anorexia, diarrhea as your kind of classic things to be conscious of. We know that there are some drugs that are more likely to induce nausea and vomiting than others, and that may mean that we're looking at giving some antiemetics such as meropenem prior to administration of treatment. So you'll kind of frequently use drugs that you may be using in practice, doxorubicin, carboplatin. I do tend to give meropenem prior to treatment and make sure that the owner has a supply at home for them to use as and when is needed. And if we have a patient that maybe is still a bit nauseous on meropenem, I do find that our Dansetran can be quite beneficial in those patients as well. If there is severe nausea, vomiting, then we have to think about maybe what happens next dose, what drug we look at giving, what dose we give to try and modify things. For anorexia, I would say that it is not something that is frequently prolonged. Certainly we can, with some drugs, often due to nausea, find that they have a period of time where they don't have quite as good an appetite. But it is important just to be aware that, you know, there could be other scenarios that are causing their anorexia. So to not have your blinkers on, and I think that goes for all of these side effects, making sure that you're not blindsided to assuming that this is all due to chemotherapy. In some cases, we may use appetite stimulants, a more enticing diet. Occasionally, feeding tubes are used. My thoughts on feeding tubes is that, generally speaking, there's often a reason why the patient maybe isn't wanting to eat. And therefore, how are we addressing that? Is that simply because of disease, therefore we need to be treating it? Is it because of the chemotherapy, therefore we need other ways to try and support them? I would say it's more common that I've considered feeding tubes in cats as they're going through chemotherapy. Maybe if they're going through a long protocol such as CHOP, that they struggle a little bit more, but the feeding tube allows for adequate nutrition while they're receiving their protocol, and then can be removed afterwards, and they will often go back to eating better at that time. So diarrhea, this is, I guess for me, being aware of it and kind of preemptively thinking about what diet the patient is on, particularly if they do have a bit more of a sensitive stomach. I don't prophylactically necessarily use probiotics, but they may, it's probably my first line in combination with diet that I might consider in a patient that does have some diarrhea. I certainly don't jump to using antibiotics as first line. We do, certainly have the indication that using multiple courses of antibiotics, which may in the short term be helpful for the diarrhea, can affect their gastrointestinal microbiome, which is, as you know, is becoming more and more evident of how important it is. So I certainly will use it in some cases, but it's not my go-to treatment for diarrhea. And as we were saying on the last slide, just make sure that you're thinking about other possibilities and not just assuming this could all be linked to treatment. Intestinal ileus is something that is most commonly seen with vincristine and more commonly in cats than in dogs. It is generally fairly self-limiting. Occasionally we have to look at some form of treatment, symptomatic treatment. And most of the time we do need to look at how we modify things moving forward, whether that is a change in dose or changing to vinblastine instead of vincristine. And actually in cats, there is some evidence that when using that for treatment of lymphoma, they don't necessarily have an altered prognosis if the vinblastine is switched out for vincristine. Alopecia is generally not too much of a concern in our patients, often a primary worry from an owner's perspective. But unless you have a breed that isn't molting, that isn't losing their coat, we don't tend to find too significant of adverse events in terms of them losing their hair. Certainly it can be slower to grow back if they've had a clip for surgery or they've had a catheter placed. And owners of certain breeds, if they're not molting breeds, it is important to make them aware that some hair loss may be more likely with them. Cats can lose their whiskers, but we don't tend to find that has any impact on them on day-to-day life. And with doxorubicin, we can see, as in the golden and the photograph there, some hyperpigmentation and facial alopecia as well. As with your other side effects, when chemotherapy is discontinued, these signs should reverse, so hair should grow back, whiskers should return. So it is all something that is reversible. Occasionally you do see patients that maybe have a slightly different hair color or slightly different texture to their coat when it grows back, but ultimately it's very much aesthetics and shouldn't cause too many concerns. Hypersensitivity isn't something that we worry about too much, thankfully, but the two drugs, just to be aware of it, in Elspar, which is something as you're aware of, we use with lymphoma. It is an enzyme, so it is a foreign protein, and therefore allergic reactions are possible. And we do find that is the case more likely after multiple treatments, which is one of the reasons that we often don't see as recommending giving lots of treatments with Elspar, also because its efficacy decreases with time as well. But if there are any concerns, antihistamines can be used prior to administration. And I do often get owners to stay in the clinic or in the vicinity for a little period of time after treatment. Your doxorubicin, it can cause a release of histamine, and therefore you can get a kind of secondary reaction from that. And this is something that typically will happen during administration as opposed to afterwards, and has been linked to speed of administration. So is one of the reasons that you generally should be giving doxorubicin fairly slowly, over 20-30 minutes. And if we do have any concerns, then stop the infusion, slow down the infusion, and give antihistamines. There's, as you're aware, a whole host of very drug-specific adverse events that we haven't got the time to go into at this point, but something to be aware of. Certainly things that you can ask us about if you've got any questions, either now or obviously if you're asking about cases. Things that should be discussed with owners, and also things that may dictate what treatment is considered. So the classic ones that we think about would be cardiac toxicity with doxorubicin with dogs, but nephrotoxicity in cats, your sterile hemorrhagic cystitis with cyclophosphamide, hepatotoxicity with lomustine. And we don't use cisplatin very often, but certainly shouldn't be used in cats as it can be fatal. So just things to be aware of, additional things just to be conscious of with treatment. So to summarize what we've gone through so far, the key thoughts in terms of adverse events with chemotherapy is that the reason this happens is because of what the drugs are doing to normal cells within the body. In veterinary medicine, our most important factor with any oncology patient is maintaining or improving their quality of life. And with that, the protocols that we're trying to devise for these patients should have low risk for serious adverse events. We should be aware that there are certainly factors that can influence the likelihood of some of these events occurring, and how do we monitor or adjust for that. But thankfully, most of these adverse events can be managed or eliminated, or things can be modified to improve the tolerability of the drug. So that's kind of all I've got in terms of going through all of our adverse events in chemotherapy. I do have a couple of case examples. I don't know whether, Richard, you want me to go through those, or want to jump to questions first, or what should we?
I think I'd love some case examples, actually. It's really useful to listen to them. Yeah,
absolutely. So we'll just got a couple. They're pretty straightforward case examples, but it just gives you, I guess, a bit of a kind of put into practice what we've just been through. And I would say, probably if we look at your various different conditions that you might be treating in practice, lymphoma is probably the key one where we're going to see some of these ups and downs in terms of treatment, when to give treatment, what's happening with your hematology. So this is Buddy. He is a 10-year-old neutered male golden retriever, and he had presented to his referring vet for an enlarged right mandibular lymph node. Blood work was unremarkable. Cytology of the lymph node was consistent with large cell lymphoma, and further staging with thoracic radiographs was remarkable, but abdominal ultrasound revealed multiple enlarged lymph nodes and a heterogeneous spleen, and cytology of those lymph nodes and the spleen confirmed a diagnosis of B-cell lymphoma. And the owners were keen to proceed with chemotherapy, so he's received his first treatment of vincristine at a dose of 0.6 milligrams per meter squared. Dose range is 0.5 to 0.7. And he was started on a tapering dose of prednisolone. And if you know anything about CHOP protocol, you will know that the patient then comes back for their next treatment 1 week later. And thinking back to what we've just discussed in the lecture, the low point, or the neutrophil nadir, is often kind of the 7-day point after treatment. And which is why, when I said previously that probably your lymphoma is where you're going to have some of those dilemmas, because it is, on the whole, probably the most intensive protocol that we tend to use for a lot of our patients, simply because they may be presenting for their next treatment when maybe the maximum effect in terms of the neutrophil count or your platelets is going to be occurring at that point. So he presented for cyclophosphamide, which is week 2 of CHOP. Clinically, he was doing well. Physical examination was in normal limits. That lymph node had returned back to completely normal. Obviously, we didn't do any internal scans at that point, but we assessed his hematology profile and found that his neutrophil count was 0.3. So we know, linking back to what we've chatted about, my cutoff for treatment is 1.5. So certainly the value is below 1.5. So no treatment today for him. His physical examination was unremarkable. He was not febrile. He was clinically feeling really well. So there's no indication for him to be admitted to clinic. However, this is a case that I would send home with a short course of broad-spectrum antibiotics, amoxicillin, clavulanic acid, something like that, and probably get him back in a few days, as long as he continues to feel fine. Now, in this case, we don't know what his neutrophil count was yesterday. We don't know what it was a few hours ago. We don't know what it's going to be tomorrow. So we have to be conscious that tomorrow maybe the neutrophil count is even lower than what it is right now. Or maybe it's rebounded and could be even within the normal limits by tomorrow. So it is very variable. And these are cases that owners need to be aware that he is certainly more susceptible and more fragile at home. I generally would recommend owners in these cases that he doesn't go mixing with lots of other dogs, that they're kind of just in and around home going for walks, but not venturing too far. And obviously, if there's any concerns with how he was feeling, that he'd be in the clinic and reassessed, with the chance that he may need to be hospitalized if anything, he starts to feel unwell, becomes febrile. But what I would expect, fingers crossed, a few days' time, his neutrophil count will have increased and he would be able to receive his next treatment. And then my second case is Rocky. So 7-year-old neutered male boxer presented with a history of PEPD and decreased appetite, enlarged submandibular lymph nodes on examination consistent with lymphoma on cytology. He was hypercalcemic on biochemistry, accounting for his PEPD, and further staging was unremarkable. And so he was diagnosed with a T-cell lymphoma. And this is his hematology profile. So this is prior to any treatment. Owners were keen to proceed with some form of multi-agent chemotherapy. What we can see on his hematology profile here is his platelet count was, he was thrombocytopenic at 59, and his neutrophil count was at 1.17. So both neutropenic and thrombocytopenic. So this is one of these cases where we know he hasn't received any chemotherapy. To confirm that maybe we have a bone marrow infiltration of his lymphoma, we need to look at doing a bone marrow biopsy. Otherwise, this could be, I guess, a secondary immune-mediated paraneoplastic. But I think that we can be fairly confident that these changes are secondary to his lymphoma, and therefore this will be an instance that I would plan to go ahead with treatment as we would hope to, with the assumption that these factors will hopefully improve with treatment due to them being secondary to the disease. So yeah, he went ahead and had his treatment. And often we can see, if it is linked to treatment, that by 1 week post the initial therapy, that we would hope things will have improved if they've had a nice response to treatment. So those are our cases, and then we will move through to questions that have come up during presentation.
Yeah, great. Thank you, Charlotte. Really good talk, really well explained, and even I could follow it and understand it as a surgeon. So really important area of our treatment of our patients. We've got quite a few questions. So the first one, Ricardo asks, what about gastroprotectants like omeprazole to help with GI side effects of chemo?
Yeah.
So,
it's not something that I will generally use prophylactically, or necessarily something that I will jump to if I see a patient that has developed any nausea, unless I feel that they have underlying maybe a gastrointestinal bleed or something like that, where I might consider omeprazole. Generally speaking, I would be looking at your kind of anti-emetics, anti-nausea medication to help with that. The one situation that I would consider things like omeprazole or something like famotidine is if I'm treating a patient with a mast cell tumor. So in those cases where we might have the possibility of degranulation, if we are treating with chemotherapy maybe a tumor that is present, so hasn't been surgically excised, then I would consider some form of proton pump inhibitor or something like Chemotherapy.
Great. Next question, quite a big question. What are your experiences with Palladia? How exactly does it work? So, I mean, I think more guidance on how it works. And I think in particular, its efficacy in squamous cell carcinoma of cats' tongues. So it's more related to cats' tongues, but also what's your experience? How does it work?
Yeah. So, yeah, I use Palladia quite a lot for varying different tumors. So as you're probably aware, there are studies that kind of look at it in other neoplastic conditions, simply because it is, I guess, it's working differently from your conventional chemo, which is targeting your rapidly dividing cells. Palladia is going to target a receptor, and that's going to kind of switch off a downstream signaling pathway. So while you can see adverse events such as gastrointestinal adverse events, you can see myelosuppression. There's factors we don't exactly know all the mechanisms by which that happens. It's certainly something that we monitor for, but the drug itself is working in a slightly different fashion. So I tend to use Palladia in cases where we have gross disease for certain tumors. So in situations where it's maybe not possible to surgically excise the tumor, and I may consider its use in those situations. I have certainly used it in squamous cell carcinomas, both in dogs and cats. I haven't had a great deal of success, more of sort of oral squames that are maybe on kind of your on the mandible, as opposed to kind of more on the tongue area. I think in cases where surgery is not an option for a squamous cell carcinoma on the tongue, then that is a possibility of a medical therapy. Other therapies that could be possible would be radiation therapy, or electric chemotherapy has also been used to a fairly successful degree on a few cases of a squamous cell carcinoma on the tongue.
Great. Another similar one, but the other end of the body. But what are the treatment options for bladder cancer, and what do you feel the prognosis is? And that's quite a wide question, depending on what type of cancer, I suppose. But
yeah, so if we go for dogs and bladder cancer, the most common one that we see will be transitional cell carcinoma or urothelial carcinoma. Most of those cases typically originate within the trigone of the urinary bladder, and therefore surgery is not always a possibility. Sometimes surgery is possible, and ones that are located in the trigone region, then I will consider the option of surgery. Sorry, if it's in the apex rather than in the trigone. If it's in the trigone, often we are talking about other types of therapy, so medical therapies and potentially radiation therapy. So radiation is probably being used more frequently for TCCs now than previously. We're learning more about it and effective protocols for its use. So radiation therapy in combination with some form of chemotherapy is probably the ideal treatment for a TCC. Treatment-wise, medically, so vinblastine is often the first line for most oncologists. There are a number of other drugs, including carboplatin, mitoxantrone, and chlorambucil, that have been used to varying degrees of success. And we tend to find that we tend to sort of stabilize, maybe decrease slightly, and kind of help manage the tumor, I would say, if we're just doing chemotherapy. But what we do find is in patients, if they develop a resistance to one chemotherapy drug, then we can often then utilize or start another one. They'll be sensitive to that one for a period of time and then move to other drugs. So I do generally find that patients can do well, up 6-12 months, sometimes beyond that. It does depend, of course, a bit of the location of the tumor. Obviously, there are risks in terms of causing an obstruction, or if we're obstructing the ureters and hydronephrosis and things that are secondary. In patients where chemotherapy is not deemed the right approach, then the use of non-steroidal anti-inflammatories are also pretty successful as a standalone therapy. You will read studies predominantly about piroxicam, but also other NSAIDs. I don't always go to piroxicam as my first line, simply because I don't tend to find that the patients tolerate that quite as well, particularly from a gastrointestinal perspective. So I will tend to pick a kind of COX-2 selective NSAID as my preference for treatment. And you can use that in combination with chemotherapy and chemo and radiation.
Great. An interesting one. Are there some specific adverse events that can be associated with intraperitoneal chemotherapy? For example, intraperitoneal vinblastine in cats.
Yeah, so I guess when you're giving anything intraperitoneal, or if you're doing it sort of into the thoracic cavity, generally speaking, there is not a great deal penetration of those drugs. So we don't tend to find that they have quite the same degree of adverse events that you might have as if you were giving it intravenously. And the question might be, is it efficacious? So is it targeting the area that we want? Of course, it depends on the drug that you're giving. So you don't really be wanting to use something that is going to be a significant vesicant into the peritoneal cavity or thoracic cavity. It's more about, sort of the penetration that you're going to achieve for the tumor that you're trying to treat. And there will be some absorption of the drug, but probably to a lesser degree than what you would have if it was given intravenously.
Right. Starving patients before chemotherapy, is there any evidence that this avoids treatment-related side effects?
So we don't tend to. We generally, I think, I guess to some degree, because it's trying to keep everything as much as possible normal life at home for patients, and certainly for some dogs where food is a key factor of them getting up in the morning, then having them have that as a normal routine and getting to eat is something that I typically prefer to do. Of course, if I have a patient that requires sedation for chemotherapy, then they have to be fasted. We don't have a lot of information or evidence in veterinary medicine at this time that it necessarily impacts adverse events or the efficacy of the treatment if the patient is fasted or not.
That's great. In the first patient, in case the neutrophil count doesn't go back to normal after 7 days, and the dog's still continuing to be afebrile and clinically stable, would you continue with a normal protocol, and will you continue antibiotics?
So the neutrophil count doesn't resolve, is that
the neutrophil count does not go back to normal after 7 days. What do you do?
So in these cases, so if we think that it's due to the chemotherapy, then things should improve. So certainly by the time, to worst case scenario, 3 weeks after treatment, unless you have a drug that can give a second neutrophil nadir, then we would expect it to improve. If the neutrophil count isn't improving, the patient is otherwise well and not febrile, then at that point we need to try and understand, is there another underlying cause for the neutropenia to be there? So is it due to the disease? Is there something else that's the cause of it, which may warrant us to do bone marrow biopsy and those kind of things? So if it's due to chemo, it should be getting better and it should resolve fairly quickly. And if things aren't improving, then we need to hunt for what the underlying cause may be.
And would you keep it on antibiotics at that stage?
If it's below 0.75, then I would keep on antibiotics until we know a bit more what's going on.
Yeah. I think we've got time for a couple more because it's just coming up to 8. But which medication would you suggest for cytoreduction of mast cell tumours?
Yeah, so you can choose a range of different options. So any of the drugs that we might use for treatment of mast cell tumours, we can use to try and cytoreduce. So vinblastine, your tyrosine inhibitors, so Masivet, Palladia, chlorambucil, so any of your classic mast cell tumour drugs can be used. It depends on the patient, depends on the owner. From my perspective, what we might use. So if we have an owner that's quite averse to IV chemo, then your tyrosine kinase inhibitors are quite a nice option. But if the owners are open to IV chemo, probably my preference is that we would give a dose of vinblastine, see the patient back a week later, see what's happening with the tumor. I sometimes find that we need to wait a little bit longer for maximum effect from our TKIs, whereas the response that you tend to get from your vinblastine, you're going to be seeing fairly quickly.
And just a similar mast cell related question, if it's c-KIT negative, would you consider palladium?
Yeah, so you can still consider it without mutation. There is that suggestion that, if the mutation is there, then they may have a better response to a TKI. But there is evidence that even without the mutation, they can respond to a TKI. So I don't necessarily make my treatment plans based on whether the mutation is there or not. There was one study that looked at patients that if they had the mutation, they got a TKI. If they didn't, they got vinblastine, and it doesn't necessarily kind of show that there's a superior outcome, and kind of choosing drug based on the mutation status. So yes, I'll still use TKIs even without the mutation.
That's great. There's 3 more. Are we all right to carry on going? Because this is really useful.
Yeah, that's fine for me. Yeah.
Great. So there's a couple on hemorrhagic cystitis, which I've certainly seen as a dramatic side effect in practice as well. So I suppose I'll go to the second one first, but is there anything to test and predict which dogs would get hemorrhagic cystitis with cyclophos?
Not that I'm aware of. I don't think there's anything that we can preemptively know which dogs are going to be affected.
Okay. And then is there anything you can use to treat it? Because obviously it looks dramatic.
Yeah, and it is. So we know certainly if a dog experiences it, then it's not a drug that we would want to use again in that patient. For me, if I'm giving, say, cyclophosphamide as part of a CHOP protocol, then I will give furosemide on the day of treatment. It's the metabolite of cyclophosphamide that can cause the sterile hemorrhagic cystitis, and therefore using a diuretic can potentially help to excrete that as quickly as possible. Also, if I'm using it metronomically, so if we're using cyclophosphamide low doses daily, then I would also give a dose of furosemide at that point. In terms of treatment, so yeah, particularly in dogs that have been on it in a metronomic fashion, so they've been on it long term, it's not easy to treat. If they've had a kind of one-off dose, then generally speaking, most of those dogs can recover, and non-steroidal anti-inflammatories can be helpful in those cases. Obviously, if you have a patient that's on steroids for a reason, then I would try weaning them off the steroids and get them onto an NSAID. There is kind of various other things that have been tried and utilized in terms of treatment. Some of the things sound not as ideal include instilling DMSO into the urinary bladder, or other therapies actually instilled into the urinary bladder. Using drugs such as the components that are in Cartrophen seem to potentially have some benefit in some patients. I've also used drugs such as oxybutynin to try and decrease this, sort of urgency and kind of spasm that the patients have. So that can be helpful in some cases. It is very unfortunate when it happens and when it doesn't resolve. I have had one patient where ultimately that was sadly the reason that the patient was euthanized. They were actually doing quite well with their tumor, but their cystitis was just not something that was bearable for the patient. So yeah, it's not nice when it happens. In patients, if they're on metronomic chemotherapy, then we do a urinalysis once a month when they come in for assessment. And also it can be quite helpful for owners to do a urinary dipstick at home once a week and just let us know if there's any evidence of blood present.
Yeah, that's great. And the final one, when do you use granulocyte stimulating factor?
Great question. Not frequently. For a lot of the cases, it's not something in the clinic that I work at. I'm not sure whether we carry it in stock. We can order it. And most of the time for these cases, by the time that you've identified that they're neutropenic, their neutropenia resolves often really quickly. And so actually the kind of, once you've identified the neutropenia, the body's already underway trying to rectify that situation. As I'd say that it's fairly rare that becomes an issue, and potentially by the time drug is ordered and it's in the clinic, you administer it, things are already improving. So it's not something that I use as a standard or necessarily that I would jump to in a neutropenic patient. In cases where we've maybe had an unfortunate situation of an overdose of a drug, then potentially I would use it in those cases, but I don't use it routinely for the neutropenic ones. I just find that on the whole, the neutropenia resolves very quickly on its own without us needing to intervene.
That's great. That's great. Fantastic. Well, I think we'll call it a day there. Do you mind just moving on to one more slide there?
Yeah.
So thank you so much, Charlotte. Honestly, it's been brilliant. I think chemotherapy oncology is one of these areas that generates so many questions. And hopefully you guys that have registered and watching today can see how we're here to help. So do use us, have a look at our services. We've got more webinars coming up all the way through the year. So just if you scan the QR code and you can register multiple disciplines, we'd love to see you there as well. Feel free to use us and start to build a relationship. Like I said, this is a new way of working in practice. It's proven to be very, very successful for general practitioners and primary vets, and just supporting and getting specialist support into practice. So it's a really exciting area and we look forward to working with everybody. But thank you for joining us tonight, and we'll call that evening there. Thank you.
Thank you.